Hello, let's talk about plasma cell neoplasms. A 63-year-old woman is visiting primary care because of back pain during the past several weeks. She's also having urinary urgency and pain with urination. She wakes up frequently to urinate. You do a BMP, you see sodium, potassium are normal, creatinine's elevated, calcium is elevated, and total blood protein is also elevated. So you do a CBC, she's got a little bit of an anemia. Her hemoglobin is at a 10.2, hematocrit at a 31, but white cells and platelets are normal. So you get some imaging done, and you see that she's got some kind of compression fractures here in the spine of a couple different vertebrae. There's one at about that's about L2 right there, and then that would be about T12. So a couple of compression vertebral fractures, along with that hypercalcemia. You're saying, okay, there's some bone remodeling going on, but particularly that total protein is really interesting to you. And because she also has an elevated creatinine, you know her kidneys are involved. So multiple myeloma is high on your list. Test question asks, what's the most likely explanation for this patient's increased total protein concentration? And this is when they expect you to know what the M protein spike in multiple myeloma is. When we say M protein, like letter M, what the letter M means is monoclonal, okay? It is a monoclonal protein because it is produced by plasma cells, which have turned neoplastic. Therefore, these cells themselves are monoclonal. You have a bunch of the exact same plasma cell, which is just an activated B cell, and it's making a bunch of the exact same Ig molecule. So in multiple myeloma, it's IgG. Now, if we were talking about this disease called Waldenstrom Macroglobulinemia, then you would see an IgM spike in the blood. So that's what Waldenstrom is. It's essentially multiple myeloma, but there's an IgM spike instead of an IgG spike, okay? So multiple myeloma, always, it's IgG, or maybe it could be IgA. Point being, the plasma cells have class switched already. That's what makes multiple myeloma, and not Waldenstrom macroglobulinemia. So they're very, very similar, but one's making IgM, that's Waldenstrom, and the other one, multiple myeloma, is making Ig anything else, okay? Here's another question. 68-year-old man with a 6-month history of back pain and fatigue. He's at the ED because of severe low back pain. So you do some routine labs and you find he's got anemia with a low hemoglobin and hematocrit. He's got normal white counts and platelets. It's a normocytic anemia. Sodium, potassium, chloride, bicarb, normal. But BUN and creatinine are hinting that there are some kidney problems going on. His glucose is normal, but calcium is a teeny tiny bit elevated. So again, because you understand that multiple myeloma has a textbook constellation of symptoms, then you're going to have that high on your list here. And those symptoms, by the way, they're CRAB, and that stands for hypercalcemia, renal involvement, anemia, and bone pain. So those are the 4 textbook symptoms for multiple myeloma, which is the most common plasma cell cancer. Back to our patient, you take an MRI and patient has multiple lytic bone lesions. You do a bone marrow, that's pretty extreme, but you do a bone marrow and you find small round blue cells and you hit the jackpot, you dug up the treasure chest, you found the multiple myeloma or the related plasma cell neoplasm. So then the question is, what's a feature present in the most likely affected cells? So because you diagnose multiple myeloma correctly, you understand that these plasma cells are making immunoglobulin. And you understand that the rough ER is the organelle involved in protein production. And notice ribosome isn't an answer choice, otherwise you might have chosen that, but rough ER is covered in ribosomes. That's why it's rough and not the smooth endoplasmic reticulum. So protein production, rough ER, don't forget your basics. Another case, we have a 72-year-old Hispanic man with a chronic cough, and he visits the clinic because of a sharp pain in his ribs that started this morning after an episode of severe coughing. So he fractured a rib, he was coughing so hard. He's been very fatigued lately and has some unintentional weight loss. You order a chest x-ray, which reveals a rib fracture, an osteolytic rib fracture particularly, so a pathologic fracture, and you do a bone marrow on that probably that rib that's affected, and you see small round blue cells cluing you in that these are plasma cells. They've got huge purple nuclei. They're very condensed. They're back to back to back. Maybe round blue cells isn't the best way to call it because that's what we call neuroendocrine cells, but they're definitely small, round, and dark. So then the question is, what lab abnormality do you most likely see? And so because you know that hypercalcemia and lytic bone lesions are part of the constellation of myeloma, you're going to say hypercalcemia. A couple answer choices that could have thrown you off here. The IgM spike on electrophoresis, man, they really wanted you to say that, but you didn't because you knew that IgM, if that were up, a bunch of monoclonal IgM means that the diagnosis is Waldenstrom Macroglobulinemia, okay? And that's the only thing that's going to give you a monoclonal IgM spike. So even though we call it M protein in multiple myeloma, understand that doesn't mean that it's IgM. It's IgG or IgA or light chain protein. A lot of different things that could be elevated in the blood, but not IgM. Then there's another one saying decreased red cells, white cells, and platelets. You can see some cytopenias as multiple myeloma or any other plasma cell neoplasm progresses, and that's going to be because the bone gets taken out, but that's going to be late in the progression of this disease. And at that point, white cells would probably be within normal limits or even elevated. It is a white cell cancer after all. Here's another question. A 66-year-old male with new onset bone pain and fatigue with exertion. Bone pain is most prominent in his back and is exacerbated with changes in position. He's running a slight fever. He's also got a productive cough and pleurisy. On physical exam, you hear crackles and increased fremitus at the left lower base. So at least this one, they're not completely giving you the diagnosis. You know, it could be pneumonia, could be Pott's disease, TB, right? Could be maybe a squamous cell or a different lung cancer that's metastasized to the spinal column. So your differential's still a little bit broad here. You get your lab values back. You're going to see moderate anemia, 8.9, hematocrit at 27. It's normocytic. And your white cell count's a little elevated. Platelets are normal, but then they give you creatinine and calcium. And that's the only other two lab values that they give you. So you know exactly where they're going with this. You have to have kidney involvement, renal injury, usually it's AKI, and you have to have a hypercalcemia to fit the criteria for multiple myeloma. And so calcium's elevated, creatinine's normal, but getting a little up there. You do a bone marrow on the guy, doing a bone marrow on all these patients, they're giving the diagnosis away, and you see these plasma cells inside the bone marrow, and that's the question. It's plasma cells. There we go. So then, of course, the other answers: metastatic bone disease, a lot of different cancers there. Remembering that prostatic adenocarcinoma likes to give you blastic tumors, another highly tested concept. Here's a 46-year-old with low back pain, weakness, and flu-like episodes. His urine output has decreased and he's got point tenderness over his lumbar spine. So you run some blood electrophoresis. Again, you're a great doctor. You know exactly what to order. And you're going to see a spike in the gamma region of this blood protein sample. And I want you to understand that this is exactly why it's called a gamma globulinemia, because it's in the gamma region on electrophoresis. So that makes sense, and it's a big spike because, again, it's a monoclonal gamma globulinemia. It's the exact same protein over and over and over and over again because this plasma cell cancer is the exact same cell over and over and over again. So it makes sense why there's a spike in that region. Here's the question: which mechanism explains this patient's decreased urine output? And this one's pretty tricky. Even if you got the diagnosis, you still want to remember that multiple myeloma gives you proteinemia, a lot of protein in the blood. And so it's going to give you proteinuria as a result. And particularly, it puts this thing called Bence-Jones protein into the urine. And Bence-Jones is just immunoglobulin light chain. But what's really important to know is that Bence-Jones protein forms a tag team with TAM horsefall protein, which is naturally produced by the epithelial cells of the renal tubules. And so Bence-Jones and TAM horsefall tag team, you know, kind of like WrestleMania or something. And so they complex together and get stuck in the renal tubules. And that's an obstruction of the normal flow of urine. And so if you've got a big crystal in the middle of your proximal convoluted tubule, as you do in this image here. Do you think any urine is getting past these crystals? No, they're roadblocks. And so what happens? The pressure builds up proximal to the obstruction. The glomerulus swells and gets damaged. There's your rise in creatinine. Okay, so that's why AKI is a big part of the multiple myeloma picture. You got a proteinemia that's going to lead to casts in the protein. Here's another example right here. We are looking at a big obstructing, basically a stone or a crystal inside the proximal tubule. And how do I know it's the proximal tubule? Well, the cells have a little hair on them. Remember, proximal tubule cells have that hair, and distal, they're just flat, they're bald. And so there's this crystal in the PCT. That's an obstruction. Pressure builds up proximally. The glomerulus gets damaged eventually. There's your high creatinine. Last practice question that we have. A 59-year-old man shows up reporting lethargy, weakness, and bone pain for 2 years' time. He's been frequently urinating, and his urine is yellow and frothy. And what I want to tell you is that frothy is a synonym for bubbly. And anytime you see frothy or bubbly urine, you're thinking proteinuria. Okay, so he's also had a history of a pathologic hip fracture a year ago. You take an x-ray and you see several small hypodense lesions in the hip and spine, so lytic bone lesions. Then you're going to test serum protein, and it's elevated, so you electrophoresis it, and you see increased gamma globulins. You know what this diagnosis is. What's the question? Well, okay, what do you see in the glomerulus of the kidney when you biopsy it? Ooh. So go back to amyloidosis. What is amyloidosis? Well, it's a disease in which different proteins can misfold into a shape called beta amyloid that your cells cannot break down. They cannot get rid of it, so it builds up inside cells until those cells die. And you can get focal organ damage. You can have amyloid accumulate in your liver or in your pancreas or in your brain, or in this case, your kidneys. And so this patient's got kidney failure due to amyloid building up. And this is particularly an AL-Amyloidosis. The A stands for amyloid, the L stands for light chain, and it's because these cancerous B cells that are clonal in nature are making a ton of immunoglobulin light chain, and Ig light chain is the protein that misfolds to give you amyloidosis in multiple myeloma. So here's what it looks like. We got a photo of it on the right hand side here. This has been stained Congo red, and notice how those glomeruli are indeed pretty red, and none of the surrounding cells are, so you know it's not a routine H&E. Only the glomeruli are sticking, and that's where you're going to see the amyloid build up in multiple myeloma. It's going to get stuck in the GBM, glomerular basement membrane, as well as the mesangium in the subendothelium. So you would see fibrillary deposits that stain positive with Congo red, thus denoting amyloid. Bunch of practice questions, highly tested concept. Let's run through this SDL and try to catch anything that we did not hit with the practice questions. So a plasma cell neoplasm, or a dyscrasia, is a clonal proliferation of an activated B cell known as a plasma cell that's making immunoglobulin against a particular antigen. So it's pretty easy to diagnose these things once you get a hunch for them, because again, you're always going to have a monoclonal proteinemia. And in the case of multiple myeloma, that's called an M protein, but the M does not mean IgM. Never forget that. The M means monoclonal. And so in multiple myeloma, the cells themselves are making IgA or maybe some IgG, but they are not making IgM. That's Waldenstrom Macroglobulinemia. So because B cells grow up in the bone marrow, these plasma cells, you know, they're mobile. They can go anywhere in the body they want, but they like the bone marrow. That's home for them. You can always go back home to your mother, you know, and so plasma cells get in the bone marrow. They start making a bunch of interleukin-1, which is also known as osteoclast activating factor. And they also start making a ton of interleukin-6, and both those are pro-inflammatory cytokines. They're going to activate osteoclasts and break down bone, hence the hypercalcemia that's characteristic of multiple myeloma. So this is a common disease. It is a disease of the elderly, median age of diagnosis 69 years. You virtually do not see multiple myeloma in a young adult or a child. The axial skeleton is most often involved, so the skull and then vertebral columns and the pelvis and ribs. This is important here. To diagnose multiple myeloma, there has to be greater than 10% plasma cells on a bone marrow biopsy. So when you take cells out of the bone marrow, you're going to put them on a slide, and some poor pathologist is going to sit and go 1, 2, 3, and some of the best pathologists, I've heard they can count up to the 6 digits, and not even have to take a break for a Snickers or anything. But you're going to count all these plasma cells, and if more than 1 out of every 10 cells is a plasma cell, you've got yourself multiple myeloma. Well, actually, we're not done yet, because you also need the presence of CRAB symptoms to diagnose it as active multiple myeloma. Otherwise, you got a smoldering or kind of a latent multiple myeloma. So greater than 10%, we're calling it MM, and then you can separate it into smoldering or active based on the presence of those CRAB symptoms: calcemia, renal involvement, anemia, bone pain, bone lesions. And if you have less than 10% of plasma cells on a bone marrow biopsy, but you have like the clinical picture, and it's a plasma cell cancer, there's just not enough of it to diagnose multiple myeloma. What we will call that instead is monoclonal gammopathy of unknown significance, or MGUS. And the way that it got explained by Dr. Buck, clinical medicine professor here, is that all patients with multiple myeloma had MGUS at some point, and it became multiple myeloma. But not every patient with MGUS is going to turn into a case of multiple myeloma. So that's how you ought to think about it. Plasma cells, they have a clock face or spoke wheel nucleus. That's how they like to tell you in words, not pictures. They could have Dutcher bodies, which are intranuclear inclusions of immunoglobulin. Here's one on the far right. They could have Russell bodies, which are cytoplasmic globular inclusions. And so you're going to see spheres or circles. If they're in the nucleus, they're Dutcher. If they're in the cytoplasm, they're Russell. Okay. What do you stain them for? You can stain them for CD38 and CD138. I love it when the numbers are similar like that. So 138 is a little more specific for plasma cells. Sometimes they express CD56, but that CD138 is what you want to write down in first aid just in case. Here is a table of signs and symptoms. The major ones I have outlined again: anemia, that's a CRAB feature; bone pain, that's a CRAB feature; elevated plasma creatinine reflecting renal involvement, that's a CRAB feature; and then hypercalcemia, that's the C in CRAB. And then pathologic fracture is also a very, very common presentation. Remember, this is the elderly, so you're usually going to be working up osteoporosis or something like that. So you don't want to bark too far up that tree before you consider multiple myeloma, because again, you want to rule out those kind of less favorable diseases first. And fatigue, generalized weakness as characteristic of just about any neoplasm. So the hypercalcemia is going to be due to osteoclast overactivation. That's how they might posit that in a question stem. And again, the overactivation of osteoclasts is because B cells make a ton of pro-inflammatory cytokines, IL-1, IL-6. They even make rank ligand. And remember, rank ligand is something that osteoblasts normally send out whenever it's time to chew up some bone. And we do have a monoclonal antibody against that is called denosumab, that is a pretty good treatment for osteoporosis. Now, renal involvement in multiple myeloma is somewhat complicated. You can handle it, but you got to read this section maybe a couple times and understand it. So 2 things going on. Number 1, monoclonal Ig light chain is directly toxic to renal tubules. Number 2, you get casts. Okay, so those are 2 different things. So monoclonal Ig light chain, we said that in multiple myeloma, you've got monoclonal IgG and monoclonal IgA. Sometimes you don't. Sometimes all you have is the monoclonal light chain. And so that Ig light chain is nephrotoxic. Now that Ig light chain also likes to form casts in tandem with your TAM-Horsfall protein. That's going to obstruct your proximal tubules, cause a backup in flow, make the glomeruli swell. There's your nephropathy. So that's one mechanism of getting a nephropathy. Also, remember, you can get an amyloidosis in multiple myeloma. That can also aggregate within the glomeruli between endothelial cells and the basement membrane. Another word for TAM-Horsfall protein is uromodulin. just in case you want to make a note of that. TAM Horsfall, uromodulin. You get anemia, again, because the bone marrow is involved. At some point, you got to almost. It's normocytic, normochromic. You do see a higher rate of infections in multiple myeloma patients owing to compromised B cell function. Amyloidosis, I summarized it here. Basically, you've got immunoglobulin light chain misfolding and forming beta amyloid sheets that can't get disposed of, so they build up and lead to organ failure. And we're going to call that, again, an AL-Amyloidosis, and a lot of different organs can be involved, commonly the heart, the liver, and the kidneys. Here is a picture of a normal serum protein electrophoresis. Notice that there is no spike in the gamma region. Okay, so if you had M protein inside the blood, that's a monoclonal protein. And 97% of patients with multiple myeloma have this M protein inside their blood. And the amount of M protein in the blood is proportionate to the cell mass of the tumor. Now, the most common Ig secreted by a multiple myeloma is IgG. Bottom of page 5, that's a pretty important sentence. So here's what it looks like on electrophoresis if you do have a bunch of IgG in the blood. Here's your gamma region on electrophoresis. And again, that's why we call it a gammopathy. And if you were to subdivide that and break it down farther, you'd see there's a bunch of IgG and IgA on this patient's electrophoresis. And then you also see some kappa Ig chain and a little bit of gamma here. And on the right, here's a different patient who also has multiple myeloma, but they've got a kind of a biphasic gammopathy. Here you've got a ton of IgG, no IgA involved here though. And then you've got a lot of the gamma light chain rather than the kappa light chain. So those are the players involved. And you can essentially have any combination of all those proteins, IgG, IgA, light chain kappa, light chain gamma. And so all these patients are different. What they have in common is that there's a monoclonal protein in the blood. You don't know which one particularly it is until you do electrophoresis. There is a proteinuria in a majority of patients. Again, if there's a lot of protein in the blood, there will be a lot of protein in the urine. And we're going to call that Bence-Jones protein, also known as Ig light chain. Here's an example of the lytic bone lesions in the skull you get. It's classic textbook for multiple myeloma. Don't really need to know genetic features. Understand you see trisomies and translocations involving the immunoglobulin heavy chain gene, and I think that'll be enough to see it through any exam question. Here's a lytic vertebral fracture, commonly a first presentation of myeloma. The pathogenesis. So virtually all multiple myeloma cases are preceded by MGUS. Everyone with multiple myeloma gets MGUS, but not everyone with MGUS gets multiple myeloma. So MGUS is defined as you have M protein, there is a monoclonal protein, but it's of a pretty low concentration. And there are clonal plasma cells in the bone marrow, but it's less than 10% cellularity. So kind of qualitatively, it's the same thing as myeloma, but quantitatively, it's not quite hit the degree or the threshold of disease that we would want in order to classify it as myeloma, because finally, you do not see Crab symptoms. You don't see calcemia, anemia, renal failure, or lytic bone lesions in an MGUS, a monoclonal gammopathy. So just telling apart the subdivisions of plasma cell cancers, if you can do that, that'll get you 2, 3, 4 questions on an in-house exam correct. How do we get MGUS in the first place? Because again, this is a precursor lesion for myeloma. Well, you get exposed to an antigen and you got a B cell that gets turned into a plasma cell, starts making antibodies against that antigen. But then the plasma cell sees the exact same antigen again, and this triggers class switching. So understand this class switching component in the etiology of the disease is why multiple myeloma does not present with a monoclonal IgM protein, because IgM is the default and you have to class switch out of it. And anytime you do, you go to G, then maybe A, then D, etc. on down the line. And so if it's IgM, that's Waldenstrom Macroglobulinemia. That's what I want you to get out of it. And then after you class switch, then you kind of get the second hit of the disease. I put first hit, that should say second hit. because this is going to be the 2-hit genetic model involving any tumor suppressor gene. Remember, you don't have the 2-hit model with an oncogene. Rather, that's a gain of function mutation. But 2-hit model, that's a tumor suppressor gene. And it's essentially going to be 2 hits involving the Ig heavy chain gene. So I think that's going to be enough to get you a fundamental understanding of what's going on here. Again, because it's that Ig heavy chain, this cell kind of gets stuck on, and so hence the monoclonal protein. Other mutations accrue, the cell kind of gets immortality, starts making copies of itself. Same exact Ig gets put in the blood, monoclonal protein. You can have an extramedullary myeloma that's not in the bone marrow. That's a very bad prognosis. And then here is an important section to round things out with called other plasma cell neoplasms. So multiple myeloma, you biopsy the bone, greater than 10% cells or plasma cells, and you have Crab symptoms. Let's go through the differential. If you were to not see any Crab symptoms, and if you were to biopsy the bone and there were to be a plasma cell cancer, but it wasn't greater than 10% cellularity, then you would call that monoclonal gammopathy of undetermined significance. So right there in the middle of the paragraph, that's what you want to know for the test. They will give you this information in a question if they want you to say MGUS. Same thing with smoldering multiple myeloma. They'll tell you that you do a bone marrow and it's greater than 10% plasma cells, but the patient does not have characteristic Crab symptoms. That's what deems it a smoldering rather than an active multiple myeloma. Then we have the solitary plasmacytoma, which is essentially multiple myeloma without Crab features. You do have greater than 10% in the marrow, but what's really particular is that this is a localized rather than a diffuse cancer. You only have one single solitary lytic lesion in this SP solitary plasmacytoma. So a lot of these do go on to become multiple myeloma, just one lesion. Then there's plasma cell leukemia, which is a more aggressive variant of multiple myeloma, where it's not just in the bone, it's in the blood too. And so diagnosis is going to be confirmed by in the bloodstream greater than 20% plasma cells. And so that's the bloodstream, not the bone marrow. You do see a monoclonal M protein here, but again, we're going to be calling it a leukemia because it's going to be in the blood, not just the bone, but also plasma cells highly prevalent in the blood. Then we have light chain deposition disease, which is defined as essentially AL-Amyloidosis without the amyloid. Okay, so in amyloidosis, there's misfolding of immunoglobulin light chain. In light chain deposition disease, you get light chain in all these tissues, and it hurts the tissues. It just doesn't misfold into amyloid, so you can't stain it Congo red, and that's about it. Instead, you see these granular inclusions rather than fibrillary tangles as you would see with an amyloidosis. So the kidney is usually hurt with light chain deposition disease. And something pretty important is that the kidneys develop nodular glomerulosclerosis, which is the exact same lesion that you develop in a diabetic glomerulopathy. Remember, those are going to be like Christmas ornaments, right? Big old Christmas ornaments inside the glomerulus. They're just pink. They're totally pink. They're acellular. And that's what you're going to see with light chain deposition disease. No amyloid staining. Then there's Poems syndrome. Memorize what that stands for. You got a peripheral neuropathy that tends to be bilateral and symmetric. And we might as well stop there because nothing else in this SDL so far gives you a bilateral symmetric peripheral polyneuropathy. So that's definitely putting Poems syndrome in your differential for the purpose of a test question. Other than that, looks very, very similar to multiple myeloma with a monoclonal gammopathy and lytic bone lesions. However, you do not see anemia or hypercalcemia, so it is a little different. But again, that symmetric bilateral polyneuropathy is characteristic for Poems syndrome. You do see skin involvement. They might hit you with the, what else would you see in this patient? And then you might have to know something just plain occult, obscure, like hypertrichosis, you know. So there is skin findings as well. There's organomegaly too and endocrine problems. And then we end this SDL with Waldenstrom Macroglobulinemia. Friends, what I want you to know is that this is essentially the exact same thing as multiple myeloma, except there's IgM in the blood instead of IgG. Other than that, you've got lytic bone lesions, you've got some renal involvement, you've got some hypercalcemia, you definitely have plasma cells in the bone, you can have some organ swelling, hepatosplenomegaly, lymphadenopathy, and then something that's particular. A couple of things particular to Waldenstrom are going to be, number one, hyperviscosity syndromes, which like to present in a fundoscopic examination. You're going to look at the eyes, and then if the blood vessels are all dilated and tortuous, there's a lot of volume in them. And then number two, because Waldenstrom has a monoclonal IgM spike, sometimes you get a cryoglobulinemia. Think back to our autoimmune hemolytic anemias. Remember that warm anemias are IgG without fail every time, and that every cold autoimmune hemolytic anemia involves IgM, like mycoplasma, for example. Okay, so if it's IgM, you can have a cold hemolytic anemia. And because you see an IgM spike in Waldenstrom, that's why you can see a cryoglobulin agglutination. Then finally, rouleaus. I'm sure all of you know what this is by now. A rouleau is just a stack of poker chips of red blood cells, and they're stuck together because there's a lot of proteins inside the blood, changing the charge in between each individual red blood cell. So normally electrostatic interactions keep them repelled properly from one another. But in the case of a proteinemia, there's a lot of nitrogens on proteins, hence a lot of positive charges. Most proteins are basic, and so that degrades the negative charge that holds red blood cells apart. And that is about it for this SDL. There's a MyD88 gene that you do want to see with, or do you want to kind of write down for Waldenstrom. But other than that, now you understand plasma cell neoplasms. Just go back through that other neoplasm section. Remember how to differentiate or classify these cancers apart from one another, and you got it. Thank you very much.